Hello, everyone. Good afternoon. My name is Amanda Schockel, and it is my pleasure to introduce our fourth session of the day for the 2023 AOCA Annual Convention and Conclave. This session will be using technology into the future. We are grateful to be joined here today by Drs. Michelle Humaden and Dr. Calvin Gross. Dr. Humaden completed her residency and fellowship in neuroanesthesiology at The Ohio State University Wexner Medical Center. She then joined their faculty in 2015 and earned a promotion to associate professor in 2020. Her doctoral work was centered on translational studies of the central nervous system and aging, and she has since remained focused on neurological research. She is the primary investigator for the Neurobics randomized control trial, exploring use of cognitive prehabilitation for postoperative delirium prevention, and she is the medical director for enhanced surgical recovery. Please join me in welcoming Dr. Humaden.
Well, I'll start while we're getting the slides pulled up here by just saying thank you so much for the invitation to come and talk to this group. I was very excited to get the opportunity to come visit with everyone, so much appreciated. So, like I said, thank you so much for the opportunity to come and talk to this group. This is near and dear to my heart, so hopefully you'll have some good takeaways and an interest to hear more about this as things develop in the future. So a couple of disclosures. I did a research study, which I'll tell you about, called the Neurobics trial, and I did have a relationship with Lumos Labs that creates the commercial product that I used for this study. So anyone can reach out to them with an idea and get support in the form of access to their software at no cost. But they never had access to any of my data or any of those things. But just a full disclosure, because I'll talk about those results. And then I do want to acknowledge the NIH for loan repayment for funds and support, and then also Ohio State for my faculty startup funds that supported the research and time that I spent doing that research I'll be telling you about. So there's three things that I want to cover, and I don't have a ton of time to talk to the group, so we're going to move through these things, and I'm really going to try to give highlights of the most important information that I want you to take away, because each of these could be an entire lecture just by themselves. So what we're going to do is discuss the importance of cognitive reserve as a predictor of postoperative recovery and break down the various contributors that either build up or whittle away a patient's cognitive reserve. And hopefully you'll be able to understand some of the limitations in measuring and evaluating a patient's cognitive reserve after our discussion. And then we'll wrap up with a discussion about the ability or the possibility that cognitive exercise might be able to help older patients recover better after surgery. So those are the things that we're going to go through. So reserve is really protection, okay? So if you have a lot of reserve, the idea is that you're protected against some sort of stress and insult. And this diagram is a classic diagram that was published by Dr. Carley, and he is really the grandfather of prehabilitation. So what you see here is this dotted line, this dashed line that goes across the graph, and that is the cutoff for functional impairment. So it could be, their physiologic reserve, we could be talking about cognitive reserve, but the idea is that when patients present for surgery, in theory, they're somewhere above this functional cutoff. They have the stress and insult of the surgery. They drop down below and are not at their baseline for some period of time. Then they recover and they get back to their baseline, or maybe even better, depending on why the surgery was done in the first place. So with prehabilitation, the idea is that you take your patient where they're starting, you do some sort of intervention to kind of boost them up above this line of cutoff. And then when they sustain the surgery, you can see they barely dip below that functional threshold cutoff, if at all, and then they recover in theory faster because you've done something to boost up their reserves. When I look at this diagram, the thing that I think about is the patients that are already below that functional cutoff when they come to us. So they're already, very heavy comorbidity burden. They're already cognitively impaired at baseline. What does their trajectory look like? And that's something that's very interesting to me in prehabilitation in general, but specifically cognitive prehabilitation. What can we do to move those patients up above that functional cutoff so that they'll tolerate the stress of surgery better? So cognitive reserve, as far as a definition, if you break it down into its most basic pieces, it's how agile your brain is to solve problems, cope with challenges like surgery, and it's really developed over a lifetime. So everyone in here that's in theory, highly educated, very curious, always challenging yourself, we have a good cognitive reserve, okay? Why is that important? Well, decreased cognitive reserve is incredibly common. I had no idea how common it was until we started recruiting for the neurobics trial in 2015. We were having a lot of patients that we had to exclude because they were showing signs of deficits on our screening exams. And I was very frustrated by that. What I should have done was publish that, because 2 years later, Dr. Culley came out with a study showing how many patients are presenting to preoperative clinic for elective orthopedic surgery. About 1 in 4, when they were being screened for cognitive impairment in clinic, were showing signs of deficits. That's a huge number. And these were patients that were otherwise normal. If they hadn't had a screening test, it wouldn't necessarily have been clear that they were having some problems with their thinking before surgery. That's important because aging is one of the risk factors for decreased cognitive reserve. As we get older, it's just one of the things that happens is our reserve can be kind of insulted over our lifespan. And a lot of older patients are coming to have surgery. So about a third of the patients we're taking care of now are older, and they have this risk of having a decreased reserve. When your reserve is decreased, things don't go well after surgery. So lots of different indicators of recovery are impaired, or not doing as well as we would think that they would after major surgery in patients that present with cognitive dysfunction. So about 2/3 of the patients that had impairment at baseline ended up going somewhere other than home. And the risk of delirium goes up when they screen positive on the screening test, which was the mini-cog. We'll talk more about that. And the time that it took them to recover and stay in the hospital was also increased. So she really exposed how common cognitive impairment is in just an average older surgical population that we would see all the time, and also exposed that risk is putting that cognitive impairment is putting them at risk for problems after surgery. So other studies have started to look at this, and now we know a lot more about how cognitive reserve is associated with recovery. So in non-cardiac surgery, older patients with diminished reserve, they have an increased mortality at 1 year. They are, again, shown to go to assisted care more than home. 30-day readmissions go up, and then various types of postoperative complications, specifically delirium, goes up as well. And delirium is very important because it's the most common complication after surgery in older patients, and it has mortality, morbidity, and cost associated with it financially, and then also to the patient and their families. So these are important things. Another study looking at cardiac patients showed the same type of relationship. The delirium risk goes up 8-fold, the length of stay goes up, the ICU stay goes up in patients that are screened positive for dementia or cognitive impairment at baseline. So what makes up cognitive reserve? Like I said, it's a lifelong checks and balances process. And so in theory, being active, challenging your brain, education, social interactions, all of those things build up our reserve. And things that whittle away at reserve include stuff that we see all the time in our patients. They present with poor health, poor sleep hygiene, poor nutrition. We see substance abuse listed there, but probably what we see more is polypharmacy, okay? And then behavioral health issues. That stuff whittles away at reserve. So it's a really complicated construct of all of these helpers and herders over one's lifetime. So Dr. Toe and colleagues did a study where they prospectively followed patients, and they used surrogates for cognitive reserve in the form of what they called late life markers. So these were things like how often the patients emailed, how did they have a musical instrument they played, did they sing, did they have social interactions, did they read the newspaper, did they do puzzles, those kinds of things. And they assigned each patient a number based on how many of these activities they said they did at least one day a week. And in their study, these were, again, older patients having orthopedic surgery. Their overall incidence of delirium was 32%, which is important when you're reading the literature for this because it's very common. And so if the study isn't reporting a good amount of delirium, you want to just be aware of that as maybe not a good assessment tool was used or not a very rigorous assessment plan was conducted. But 32%, so very, very in line with what you would expect for this patient population. And the patients that had a lot of cognitive reserve based on this point system, they had the lowest risk of delirium. So what you see in those bar graphs there on the left, the delirium incidence was about double, so 60% in the patients that had low points, so 0 to 6, and it dropped all the way down to less than 10% for the patients that had a lot of points. And each point ended up being associated with a decreased delirium risk of about 8% each. And so that I thought was so interesting. I'd already started the neurobics trial when this study came out, but I felt encouraged to keep going based on this. So let's talk a little bit about the limitations of measuring reserve because it's not a completely a simple thing to wrap your mind around, okay? So since 2012, we've had expert guidelines and expert consensus helping guide us on how to prepare older patients for surgery. And so a joint effort with the ACS, American College of Surgeons, NSQIP, and the American Geriatric Society group, they came together and published these guidelines, like I said, in 2012. And part of this is a very robust screening assessments for all different kinds of things, including frailty, nutrition, and cognition. Since then, there's been an explosion of interest in cognitive health and brain recovery after major surgery, particularly in older patients. And the ASA has made this really a priority, and other professional organizations as well. So now there's really no shortage of information on what we should be doing, but how feasible it is to do these types of assessments is another question altogether. So you can find expert guidelines from a variety of different people on what we should be doing to assess older patients, particularly their cognitive reserve, because that's an important indicator of their recovery risk, like I said, but the feasibility is challenging. The takeaway from all of those, if you read all of those guidelines, is that all at-risk patients should be getting a preoperative cognitive screen. And what we're looking for is an indication that their cognitive reserve is already below that functional cutoff. Okay, they're already showing signs of deficits when we screen. What's at risk? Well, the American College of Surgeons says your age. So if you're over the age of 60, then you should be screened. Other things can also put you at risk as well, a history of delirium, frailty, those types of things. So really, all older patients should probably be getting a cognitive reserve screen at baseline. So a recent publication put together a list of the rapid in-person cognitive screening tools that are available to us, specifically to be used in a preoperative setting. Any guess on how many of these there are? Just throw out a number, anybody. 5, 10? There's a lot. There's just shy of 30 different assessments that you could pick from to get an idea of what a patient's cognitive reserve at baseline. I think that's a little overwhelming sometimes to the average person that's trying to do right by their patients. So out of that list, we'll talk about a couple. In particular, the mini-cog is by far the one that's most used in the literature and research studies. It's very feasible to do, does have some limitations, but we'll get into that in a second. But you can see This is the list they came up with for the ones that meet criteria for being a rapid screening test. It's quite a few. And I think that that's one of the reasons why, even though we know, and we've known for many years now what we should be doing, our compliance with those recommendations is pretty poor. Dr. Diner published this survey study showing that most of the respondents to her study said they do take care of geriatric patients frequently, but they estimate that the amount of screening that's happening, that's supposed to be happening for frailty, cognition, and the like, is 10% or less. So really, really low compliance. And there's a lot of things that play into that. People are busy before the operating room. It's complicated, and I appreciate that, and I've learned more and more about that as I've tried to implement some of these things. But nonetheless, we know we should be doing it, and our compliance is pretty poor. So I hope to give you a couple of options to go home and think about that you could use to actually screen your patients, and then a little taste of what you could do to maybe mitigate their risk, because that's really the question. If we screen these people, what do we do with them once we know that they have a deficit? We know their risk is increased. What do we do? That's a whole talk by itself, but I'll give you a couple of tidbits for practical use, hopefully, when you leave. So back to the ACS guideline here. They have a nice, robust explanation of the mini-cog. And basically what it is it's got two pieces. There's a word recall, and then there's a clock drawing test. And so you administer this to the patients, or your trained staff does in preoperative clinic, and that's what Deb Culley used in her study that showed this association between the mini-cog score and all of these, the discharge somewhere other than home, the delirium risk, and the length of stay. So just to give you an idea of how this looks if you do it, there's a normal clock there on the left drawn by an older person, so maybe some tremor or things like that, but it's normal because what you tell them to do is draw a circle, fill in the numbers, and then I want you to put the arms of the clock at 10 past 11. And it's really important that you say it that way because that's how they have to process that information and do it right. So there's some examples of how an abnormal clock would look. And it's beyond the scope of this to get into how that's scored, but I just wanted to show you it's a pretty quick assessment. If you're feeling intimidated about the mini-cog, please take the time to watch Dr. Gina Blitz's webinar on how to do this. She actually films a patient encounter where she's giving the mini-cog, and it's wonderful because even as a cognitive research person, I myself am guilty of not doing this because I do feel like it's challenging. It's hard when you're first meeting the patient to get into this type of a conversation with them, and this webinar addresses a lot of those things. It's free. It's sponsored by some grant funding. It's worth the time, and it specifically focuses on the mini-cog. So takeaways from that webinar that I wanted to share with you, and hopefully you'll follow up and watch it in its entirety, is they really focus on like, how do I talk to patients about cognitive reserve and their baseline? And what you want to do is emphasize that you're taking vital signs, just like you would for any other organ system, just like we check blood pressure, we check a weight, we check temperature. All of those things are vital signs of the organ systems in the body. The cognitive screen is just the same, and it will help us plan for surgery and recovery better. We'll talk a little bit more about that in a second. It's not diagnostic, so the screening test is just meant to help us get that initial assessment of risk, but it doesn't mean that their surgery is going to be canceled. I think that's the number one thing that patients worry about when we introduce the idea of getting a cognitive vital sign from them, is they're afraid it's going to affect their ability to be a surgical candidate, and that's not true. We just want to know what the risk is so we can maybe mitigate the risk a little bit. And then practice. Don't be afraid to do this, okay? So the rapid in-person publication that listed out all of those different tests, they have this nice sequence of things here that's tough to read, but I just wanted to, I put it up there to cue me to tell you a few things. One, all of the arrows go to surgery. So if you screen a patient and they're normal, you go to surgery. You screen a patient and there's a deficit, then you can kind of decide, do they need formal evaluation, or some other type of pathway to get them ready for surgery, but they still end up at surgery. And so I circle up here, you alert your stakeholders if you have a patient that is showing they have cognitive impairment at baseline, because then the discussion can start happening about what we can do to mitigate that risk. Our options aren't great. That's part of what I am researching to try to understand, but we can do basic things like adjust our MAC fraction for age. That's basic stuff we should be doing for all older patients. If you're skilled with EEG monitoring, you can use that to titrate your anesthetic. Not a specific device that I'm recommending, but just in general, the raw EEG if you have access to that. Again, maybe avoid benzodiazepines, avoid, meperidine, these Beers criteria medicines that aren't good for old people. If you know someone's at risk, these basic interventions might help them do better. And again, we still end up at surgery. And the question that I'm going to get into next is, how do we start thinking about protecting what they already have versus building it up? So if whatever they're coming to the table with, we don't want surgery to knock them down even further, but protecting what they have and building it up are two different strategies. And so the research that I do is actually not on protecting the reserve they have. A lot of the clinical things that I mentioned that we can do is aimed at doing just that, as is the Hospital Elder Life Program. That's a fundamental delirium prevention package that was originally done in hospitalized patients, but has been done in surgical patients with very good effectiveness on preventing delirium and promoting a good recovery. But it supports what's already there. And so we want to talk about what to do to build up the reserve if it's possible. So if the mini-cog intimidates you, you can do something even simpler, which is just ask the patient, how many years of education have you completed? We should be doing that anyway, because it does affect how we rank the applicability, if that's the word, of the screening test that we would be using. So the mini-cog in someone that's not completed very much schooling is not as reliable as it would be in a patient that had done more schooling. So you want to know what their educational level is at baseline. That also affects other important things that we're not going to get into today, like their health literacy. But it's a good surrogate for cognitive reserve that's promoted by Dr. Price at Florida. And if you have a low level of education, it does associate with poor postoperative recovery, emergency room visits, and things like that. So we should be asking that to make sure the screening test that we're using is appropriate. But even without that second step of a screening test, if you just know that you have a patient that has not very many years of formal schooling, that's a good surrogate for their cognitive reserve, and you know they might be at increased risk. And 50% of individuals over 65 have less than a high school education. That's an astounding number that I did not appreciate until I was reading some of Dr. Price's literature. So it's very common, super easy question to ask, and can help you understand what their risk is. So like I was saying before we started, we optimize all of these organ systems, but we don't talk about the brain at all. And that's where my research has started, with that really profound interest in trying to optimize the brain before surgery. So the last several minutes here, I'll talk about using cognitive exercise to try to build up the patient's cognitive reserve so they tolerate that stress of surgery better than they would have without it. So when I was in residency, this paper came out in 2013 talking about video gaming and how it improved cognitive abilities in older adults. And it was in Nature, so you've probably heard of that. It's a pretty big journal. And so this caught my attention, and the study is so cool, and it kind of set me on my path to the neurobics trial. What they did with these patients was they had young and old patients that they were comparing their performance, and they went on to train some of the older patients with an exercise task and then see how it affected their cognitive abilities at 6 months after the training. And so the task, they had a drive-only piece where they had a joystick and they had to keep the car in the lane. They had a sign only, so they had to click a button when they saw a green circle, not a green square or a red triangle, just the green circle. And then there was a paradigm where they had to do both at the same time. And what they found with this was that, as expected, the older patients, they had a tougher time with multitasking than the younger patients did. So the 20-year-olds are on the left there. When they had to do the multitasking, the driving and the sign recognition at the same time, there's a cost to splitting your attention like that that will affect how you do on either of those tasks by themselves. The older folks are more impaired on multitasking. So they went on to give a cohort of the older patients training with just the sign task, and they went on to a different cohort and trained them with a multitasking intervention where they were doing the sign and the driving at the same time. They did this for 12 hours, so 3 times a week for an hour over 4 weeks. So not a huge amount of time that had to go into this. And what you see there is the red line on the bottom are older patients that didn't get anything. And so they, their baseline performance and what it was at 6 months shows kind of an additional decline in function. The green line is showing the patients that got trained on the single task. So they didn't get the multitask training, they got single task. At a month, they were improved in their performance, but it was not the same at 6 months. They kind of lost that benefit. But the patients, the older patients that had the training with the multitasking brain exercise, they had really robust improvement in their performance at 1 month, and it was sustained at 6 months. And they did a follow-up study 6 years after this, and there was still benefit there from 12 hours of preoperative cognitive training. And if you look at the top, the blue, the highest mark in the patients, the older patients that did the multitask training, the highest mark there is actually better than their 20-year-old cohort performed. So we could actually train these older people up to be even better than the young folks. There's EEG evidence of the mechanism of how this is working. They looked at some of the theta waves and EEG signatures of things that are known to represent working memory, sustained attention, and they were able to show that the older brains started to look like younger brains after this training. They did a couple of different examples of that with theta waves in particular. And then they also looked at transfer of this ability to other cognitive tasks that were evaluating working memory and sustained attention. And so the older folks that got this multitask training for 12 hours, they did much better than their people that didn't get the same kind of training and were actually on par with much younger patients. So that got me super excited to do the neurobics trial. I thought, what if we give this brain exercise to patients before surgery? What could happen? And we started this trial in 2015. We used older patients that were cognitively normal, which is important. We did a screen, mini mental status exam. They were all normal, no deficits. And we randomized them to intervention or not. And this was the intervention that they did. So it's a very similar type of challenge in the sense that the patients are switching tasks, they're getting constantly upgraded, so the better they perform, it changes to challenge them more, so it's dynamic, which is important, and there's all different domains of cognition that are part of this training, so memory, speed, attention, flexibility, problem solving. We asked them to do 10 hours, not 12, in the weeks before surgery. And that was important because I could actually monitor their compliance. So even though Dr. Toe says if you do crosswords before surgery that you can have benefit from that, for research I needed something I could actually quantitate. So we published the results in JAMA Surgery, and what we showed was that we had 268 total patients, and in our intervention group, the delirium rate was 14%. In the control group, it was 23%. So to me, that was so exciting because these were patients that were normal at baseline. So they were on the lower risk end of the delirium spectrum because they were normal to start with, and we still had a benefit. And they played about 5 hours, a little less than 5 hours, so not the 10 hours that I wanted. But it turns out that might be okay, because if you do a dose response, the patients that played less than 5 hours, their delirium rate was about 18%. But when you got to 5 to 10 hours, the rate was 10%. And there didn't seem to be an additional benefit for playing more than 10 hours, at least in this first study of this type of work. So there's been a few studies come out since this, or around while we were doing this. It took 5 years to do this trial, that are looking at similar things, not exactly the same, but similar. And so there's a review that was published just a few months ago, meta-analysis. And for post-op delirium, it looks like there's some good promise in doing brain exercise of different kinds to prevent delirium, but not significant. Again, it's only 5 studies that are included this, and most of them are feasibility trials, not the neurobics trial, which was a randomized controlled trial. They do show benefit for longer-term cognition problems, which is interesting. And again, the point of this is just to show you that we're really in the infancy of studying cognitive exercise to promote recovery. So Dr. Velicities, he's at Michigan. He did one of the pilots or feasibility trials that was included in that review. He published a nice commentary on things that we should think about going forward. And I already mentioned them. We want the patients to be challenged. We need to have a dynamic, interactive modality when we're doing these brain exercise video games. And we need to improve our compliance. So we need a way to get the patients to actually do the intervention. So going forward, that'll be something that we're all thinking about. Outside of perioperative medicine, plenty of other folks are studying brain exercise to promote good cognition in older people, and they're saying the same thing. You want to have it be dynamic. It needs to be something that patients can interact with without limitations because they're older, and it needs to basically keep challenging them. So they're saying in the future you might see stuff like this, where you have a patient doing physical exercise and cognitive exercise there on the left with their screen. The next picture, she's meditating, so she's doing some behavioral therapy with her brain exercise. Then you have full-on immersive virtual reality, so that's being studied. And then way out there, I think, is using stimulation of the brain through electrodes to actually augment the way that the brain responds to these types of exercises while the patient's doing them. So really getting exciting in the future about this. Keep an eye out for Dr. Hughes at Vanderbilt and Rangel, Hughes and Vanderbilt at Rangel. They're doing some cool work with exercise and cognitive, physical exercise and cognitive exercise at the same time. That's really, I cannot wait until they get this work published. They're actively doing that study. And a couple other things, if this feels way out there, like how am I going to get my patients to do brain exercise? It's really in the realm of research right now, but what you can do is help encourage patients to sleep well before surgery. You can promote opiate-sparing pain control, and you can do other things like, this is a bookmark on the far right-hand side there that Dr. Price gives to patients at University of Florida as part of their PenCan initiative. And it says, stay hydrated, take your medicines, get some physical activity, be social, interact with people, all of those things to help boost up that cognitive reserve if this exercise stuff seems a little bit down the road for you. There's other things we can do. So that's everything I wanted to cover today. I hope you got a few takeaways about how important cognitive reserve is. We're really understanding a lot of our patients are showing up with issues at baseline now, and that's important. And what can we do to measure that? It's challenging. But even if you just ask, how many years of education have you completed, that can give you a little bit of an indication of what their risk is. And then I think down the road, brain exercise with gaming will become more and more something that seems feasible to do. But in the meantime, do other things to promote good cognitive reserve, like sleeping, eating well, staying hydrated, taking your medicines, being social. All those things can help protect our patients. Thank you. I'll stay up here, right?
Thank you so much. Our next speaker is Dr. Gruss. Dr. Gruss is an assistant professor of anesthesiology at Vanderbilt University Medical Center with a a really diverse academic background, including an MS in clinical informatics. Dr. Gruss brings a unique blend of medical expertise, including data-driven insights to the field of anesthesiology. In addition to his clinical practice, he is actively involved in teaching at the Vanderbilt School of Medicine, imparting some of his knowledge and passion to future healthcare professionals. And he's also driven by enthusiasm for systems optimization and leveraging clinical support tools. He focuses on enhancing the quality of care of his patients with his experience and expertise. And he is on the forefront of utilizing data on interoperative management to improve patient outcomes. Please join me in welcoming Dr. Gruss.
Thank you. Hi, everybody. I'm really excited to be here and to have a discussion about data and its power to affect change today. So that's where we'll start. Okay. No conflicts of interest, so that makes it easy. And so this is just a brief timeline of like what we'll talk about today. So we'll start today with how we got here. When did all this data get here and why? And then we'll look at the data models and sources available for us to use. We'll take that data to try to improve patient care midway through. And then I'll emphasize the word to try because as you'll see there are failures and successes with any time we try to use data. And then finally we'll end with a look at the future and what we're likely to see hopefully coming through the pipeline. So in the not so distant past, medical discussions were made mostly by clinical gestalt, which is really just a fancy way of saying pattern recognition, which is a little bit of foreshadowing because as we'll see, we can now use technology to recognize patterns for us probably better than we can. However, there was a rapid rise in EHRs, AIMS, which are, as most of you know, anesthesia information systems, and data repositories in the early 2000s. And so, why did that happen? And so what we see is, High-Tech Act was signed under President Obama, which allocated over $20 billion in incentive to incentivize and implement electronic health records, or EHRs as I'll call them. And then in 2016, the 21st Century Cures Act came out, and this aimed to make healthcare information more accessible and transparent. And so with that, we see there's $20 billion of money going towards the implementation of EHR, data utilization, and then data storage. And with that, you see an exponential rise in the EHRs that we see around the US. And so almost all hospitals and physician offices in the US now have successfully transitioned from paper-based medical records to electronic health records. As of 2021, 96% of all non-federal acute care hospitals and nearly 4 in 5 office-based physicians have implemented a certified EHR. And at that same time, as we've been having these electronic health records across the country and across the world, we've also seen a rise in almost all hospitals. We've seen a rise in the ability to store data and to fit chips into smaller and smaller compartments, and more chips in those compartments. And as we can see from this slide, the ability to store and process data has continued to grow actually it is exponentially. So Moore's law, which states that the number of transistors on an integrated circuit chip doubles roughly every 2 years, and that continues to be accurate even through 2023. So now we have all these incentives for EHRs, and we have the technical capabilities for all this data storage. So what do we do? And so that brings us to our next step. So what do we do with this data, and where is this data? Well, the first thing we do is we store the data, and that can look very different based upon your institution, your preferences, and even what you intend to do with the data. We'll look at a few examples quickly, and this is meant to just illustrate all of the options available to us. And as you can see, this is kind of the framework for something that we have at Vanderbilt, but a lot of institutions across the nation, private and public, have similar models. This just illustrates how there's multiple data components that go into this homegrown perioperative data warehouse, and we'll touch on each of them, which are readily accessible across the nation and likely at your institution or practice. So The first one that we'll talk about is the Anesthesia Quality Institute, and they put out the National Anesthesia Clinical Outcomes Registry, which is NACOR for short, and it's a voluntary data submission registry that collects data from anesthesia practices and hospitals. The practices that contribute to NACOR include 13,905 physicians, it's probably going up, 9,324 nurse anesthetists, and more than 3,500 residents and nurse trainees. These practices represent 20 to 25% of the national workforce, and they submit data on all their cases in all settings. And so this is actually the largest national anesthesia database that's available. So, referenced in the previous talk, another one that's really prevalent and used is the National Surgery Quality Improvement Plan, or NSQIP. And NSQIP data is particularly important because of its high fidelity, its prospective nature in the way it's collected, and much of it's gathered by medical chart abstraction and not otherwise available for quality review. And just to give you a bit of a picture as to what that looks like rather than try to just describe it in words, you can see that this medical information is taken out of the chart, and it starts on the left side. Over 150 variables are then collected from these patients' chart, and then the data is entered into a web-based system. And then that is then corroborated by interrelated reliability, so you can make sure that the data that you're getting is accurate and that you can use that data moving forward to make your clinical decisions. So another option, many of you have Cerner, Epic, whatever your health system may be. A lot of those resources also have databases or data models within them. And so we have Epic at Vanderbilt, and one of the three paradigms that you can use, which in Epic are Chronicles, Clarity, and Caboodle. All of them have slightly different abilities and capabilities, and depending on what you're using, you can use those to analyze patient data as well. Whether that's just asking a quick question through Slicer Dicer, which is a program inside of Caboodle, which you could do on a Wednesday between cases if you just wanted to look up a random fact about OR cases, or if you wanted to use a report bench program, which would be in Chronicles. And so this isn't a nitty-gritty lecture on all the capabilities of these databases, but just to give you an idea of what you can do. And then the last one that we'll talk about right now is the Multi-Center Perioperative Outcomes Group, or MPOG, and that's a nonprofit organization that uses electronic health data to improve patient care and has over 100 investigators, over 51 hospitals, as you can see across the nation, 21 states, and even 2 countries. And their objective or their target is to use healthcare data to analyze the interplay between patient comorbidities, surgical procedures, perioperative care, and postoperative outcomes to support quality research. So that's a mouthful. So that's just a couple of the options that you now have to harness patient data and affect change and improve outcomes for your patients. So the first step is knowing that the data is there, and then the next step is, what do we do with that data? So there's so many ways to analyze data now, especially in this age of AI, which we will address a little bit later in the talk. But at its basics, I like to split it up into just like, we'll have some shared vocabulary for this talk. And the 3 things I like to start with is logistic regression is the tried and true method that many analyses have used and is effective. And so for a logistic regression, I put it up there, but it's the prediction of a binary dependent variable by a combination of independent variables. And so what does that really mean? So I always like to think of it as a question of, will the patient have postoperative nausea and vomiting? Yes or no? Will they have a serious hemorrhagic event? Yes or no? Will they die within 30 days of surgery? Yes or no? So then looking a little bit further, what is artificial intelligence for the sake of this talk? And so artificial intelligence is, a computer system that's able to perform a task that normally requires human intelligence. So that, at its base, that's all it is. And so this lends itself to tasks that typically don't have binary variables like image and speech recognition or decision making. And then the third word I like to use is this idea of like augmented intelligence. And so augmented intelligence is the idea of just improving humans' ability to make clinical decisions. So really that's taking technology, combining it with a human system or a physician, and then being able to empower them to make better clinical decisions. And then some topics that we'll touch on in just a bit are the ideas of this term that you might hear around a lot about machine learning or deep learning. And machine learning at its core is just the ability of your algorithm to progressively improve their performance on a specific task. So unlike classic algorithms where you set it and forget it, machine learning is able to grow with new information and build a better and better model to answer the questions more and more accurately. And then deep learning is the idea of learning data representations as opposed to a task-specific algorithm. So that's understanding the data on a more holistic approach rather than just putting in some inputs, analyzing them to get a specific output. Okay, so with that, we've seen the data. We've now defined some classic and novel analytic techniques. So now let's just look at some examples and see what that really looks like. So the first thing we'll do is we're going to look at clinical decision support and clinical decision support systems. So many of you are familiar with clinical decision support, or CDS as I'm going to abbreviate. These are all those recommendations and suggestions that pop up while you're using your electronic health record. Some of them are useful. Unfortunately, many of them are annoying, distracting, and not beneficial to your workflow or to patient care. However, they're designed with good intent. They incorporate clinical guidelines like PO&V recommendations, glucose monitoring guidelines, antibiotic prophylaxis, and they combine that information with specific patient characteristics to present the end user with care recommendations. So that would be you, me, an intraoperative, the person managing your case in the OR. But unfortunately, it's much easier said than done to make this system of getting the right information to the right individual. And why is that? And it's because there's so many things that you have to consider whenever you're trying to get to do that. So how do you optimize the care of your patients when there's a lot of opportunities to get derailed by unforeseen obstacles? And so that's why these design principles that have existed for decades have been in place. But at the end of the day, you want to try to think about how do you get the right information to the right person in the right format through the right channel at the right time. And so one of the things that happens is one of these that we struggle on a lot of the time is at the right time. You know, sometimes when those pop-ups happen in the EHR, it's either not the right time or it's not the right information, and we just click out of them because it's not useful to patient care. So knowing that those are the principles, now let's look at some failures first and then some successes of CDS. And so the first one that I can think of was just a quick little best practice advisory that we tried to roll out at Vanderbilt. We made a model for postoperative nausea and vomiting risk factors at our institution to suggest the use of a scopolamine patch, which we use pretty prominently for anyone with risk factors based on our department guidelines. So female, non-smoking, postoperative opioid use, and then history of PONV or motion sickness. And that's really what this linked criteria tells you. And for anyone who has 3 or greater, the clinical decision support tool then pops up and has this nice little recommendation of saying, hey, would you like to order a scopolamine patch? And so we rolled this out thinking it would be wildly successful and that everyone would order these scopolamine patches when it was clinically indicated. Unfortunately, as you can imagine, that wasn't the case. And these numbers are kind of small, so I'll just tell you them. So this fired over 300 times per day, which is what we expected it to fire. We expected the CDS to alert this number of times for the number of patients that we do at Vanderbilt. But at the bottom of the corner, you can see the number of times that it was ordered, and it was actually ordered 2.6% of the time. So out of those 300 firings, less than 6 patients are getting a scopolamine patch ordered. And so that just lends itself, in one of those 5 rights of clinical decision support design, like we did something wrong. And so then you have to take a step back because a failure is only a failure when you give up. There's a couple different ways that this initially happened. And one of the reasons why is whenever you open this preoperative navigator, the best practice advisory isn't readily apparent on that screen. And in our institution, most people look at the banners and the procedure info, and then they jump down to the red arrow for pre-evaluation, and they just they never see this screen because of all the clicks that they do. And so the reason that no one was using it is because no one was seeing it. And so to improve the compliance of clinical decision support models in general and for the future, one of the things for this specific one is you can increase the priority of the BPA from important to critical. Typically, with critical alerts, you have to save them for something that is, truly critical, again, to mitigate alarm fatigue. So that's not something we necessarily wanted to do. You can change the BPA from passive to active, and that just means it turns into a pop-up. Those really annoying things that none of us like to do. So again, not the best option. We can actually just move it up the screen so that it's above, it's high enough on the screen so that when the screen opens that it's readily visible, and that's probably the best bet. And then on top of that, you can also use education on BPAs and grand rounds to let people know that these resources are available, which is something we've continued to do with new iterations of things that we roll out. Because if you communicate with your personnel and your staff of the availability and opportunities of these programs and BPAs and alerts, then the buy-in can be significantly higher. And so that first example illustrates something that I like to think about whenever I'm doing something in clinical decision support. And it's the immediate change to improving the quality of surgical care is not discovering new knowledge, but rather how do we integrate what we already know? Because we already know so much about how patients do well. We know how many antiemetics to give. We know how many times glucose should be monitored perioperatively. Like, we know all of these answers, but yet compliance is still shockingly low. And so the idea, I think, moving forward into the future, first is taking that information that we already know and using it to administer the best care to our patients that we can, and then moving forward using technology and artificial intelligence to move even beyond that. And so now a successful illustration of something we did at Vanderbilt was with intraoperative glucose monitoring. And so this is a preoperative assessment, and the green arrows are the places where diabetes is documented or charted, along with a blood glucose level or insulin administration. So that's a preoperative assessment. And then this is a nursing preoperative assessment, which is immediately prior to surgery. And green arrows indicate anything tied to an endocrine assessment, whether it's documented diabetes, a blood glucose draw, insulin administration, or whatnot. And so then with this clinical decision support model, any patient who either had any of those factors, whether it was a diagnosis of diabetes, preoperative assessment with blood glucose being drawn or insulin being administered, they would then get intraoperative alerts in their medical record on the hour. And so every hour you would get this if your patient had any of those parameters before. And the whole idea of this was to increase compliance of glucose monitoring perioperatively, which had been lacking in our institution. So this gets rolled out, and unlike the PONV metric, which wasn't successful, the intraoperative glucose monitoring was wildly successful in the sense that if you can see from the results, we went from 61.6% to over 87% in terms of compliance of monitoring glucose, so just measuring the values. Hyperglycemia in PACU dropped from 11 to 7%. Hypoglycemia didn't really change, and then the surgical site infection fell from 1.5%. And so that was like a 55% relative risk reduction, and that actually saved the department over $600,000. So clinical decision support can be annoying and inefficient or inaccurate. It can be effective and save patients time, energy, resources, money, and hospital dollars. So now that we've seen some of the ways to optimize patient care through clinical decision support, what does the future look like for data management and data utilization? And so we saw this slide a little bit before, but now we're going to take a look at it in a particular type of deep learning, neural networks. And so a neural network is a machine learning model that uses algorithms to mimic the human brain. And I feel like that's best illustrated through a picture. And so this is kind of an example of what you can think of it. Think of your human brain getting input through a source, whether that's visual, sound, and then processing through a bunch of neurons. This system processes through multi-layer. They're called nodes here, but nodes are really just the neurons of your brain. And then there's an output or a decision like you or I would make on the other end. And so the number of layers can be many, it can be few, and typically they're hidden. And the term hidden is why we describe it as deep learning, because a lot of those layers aren't seen by the user or the interface. So this isn't a neural network talk, so we'll jump to some examples just to show you the power of it. So echo interpretation is something that artificial intelligence or neural networks can do really well. In this particular study, there was an image data set of 14,000 echoes that were looked at, and then they used convoluted neural networks to develop a system that could identify the view, and then it could also calculate the volume, the LV mass, and the ejection fraction. And then it could also make a diagnosis of HOCM or hypertrophic obstructive cardiomyopathy, amyloidosis, and pulmonary arterial hypertension. And it found it could do this reliably at the level of a cardiologist. And so it's fascinating that given this gross amount of data, again, 14,000 echoes, that you can then use these views and get accurate diagnoses where, HOCM could be diagnosed with an area under the curve of 0.93, cardiac amyloidosis at 0.87, and pulmonary arterial hypertension at 0.85. And so this just shows the power. And so even if you assume that we're going to continue to use cardiologists, as we will, this can expedite the ability to read them and process them and stratify the risk and get those echoes that have true critical alerts to the right people in the right time. Another example is in like the ASA prediction of your ASA scores. And so the ASA has this physical status score. And so can we optimize that rather than making it a physical human task that needs to be done? And so this study looks at EHR data. It just took diagnoses of patients, their medications, and it looked at over 419,000 charts. And it tried to do two things. One, it tried to predict a risk score, and then it also tried to make a risk score on the entire spectrum of ASA scores. So rather than the classic ASA scores of 1, 2, 3, 4, 5, it gave you a score of 2.5, 2.7, 3.3 to give you a more comprehensive assessment of that patient's perioperative risk. And again, we use these supervised neural networks, and the study showed that the risk stratification performed as well as anesthesiologists. So the idea here is, we're not going to get rid of anesthesiologists, but could you use these in pre-op clinics for triaging or rank ordering by acuity that information? And then another example, so in hospital mortality prediction, this is done with deep neural networks, and they looked at 60,000 patients and over 87 features, and they found that the neural networks performed as well as logistic regressions, and this is just a good example, I think, that neural networks and artificial intelligence aren't always going to be the best answer, the brightest answer, but they're still going to be possible, maybe not superior. So hospital prediction, in-hospital mortality prediction was as good, but not better than our classic tried and true method. So I always like to put this in here to tell you that I feel like we're all talking about AI, and a lot of vendors and advertisers are always trying to incorporate in these buzzwords, but sometimes the tried and true method of classic logistic regression and linear regression can be just as effective in determining outcomes. And then one more example is the ability to predict hypotension in the OR. So we looked at this AIMS data of over 1,300 records and basically 545,000 minutes of arterial line data, and we tried to predict whether or not you could predict hypotension 15 minutes prior to an event. And so this picture is a little small, but you can see that each cardiac cycle, they have over 3,200 data points, which is the calculation there. And so those 3,200 of data points per cardiac cycle multiplied by the time period leads to just a gross amount of data. Again, that's like 550,000 data points. And so something that you and I can't process, but a computer can, has the capability. So after looking at those 3,000 individual features per cardiac cycle, they could identify with shocking specificity and sensitivity the ability to predict hypotension intraoperatively. And you can see in this figure is just an example of one patient. The map is on the top graph, and then the ability to predict the risk is on the bottom graph. And it just shows that as the likelihood on the bottom graph goes up, you can see the map is downtrending and just very reliable, just because there's so much data that we can't elucidate, those 3,200 data points individually by ourselves. But with the power of data processing and artificial intelligence in the sense of neural networks, we really can. So I think that's the future that we see. But at the end of the day, I always like to come back to, like, how do we make it, how is it good now, and how do we make it better for the future? And so I think with decision support with artificial intelligence, we can't have a lot of black boxes. We need transparency so that the users can understand the basis for these recommendations. And we'll give you an example on the next slide of why I really think it's important. It has to be efficient in the sense that it blends right into our clinical environment. We don't need these alerts. We need these alerts in the right time, in the right place, and in the right space. And they have to be intuitive and simple. Anesthesiologists already working in the setting should be able to use them, or CRNAs, or whoever the people may be, need to be able to use them without going through 40 hours of training every 8 to 10 weeks. And the reason, again, why I say that about the transparency is because there's sometimes when things aren't transparent and then we have no way of validating or verifying them. So this is an article that came out in Wired about an algorithm that predicts deadly infections. Sepsis is often flawed. So this article in Wired was referencing a study done by the University of Michigan that took data from basically 30,000 patients and was using Epic's sepsis predictor on those patients. And the authors found that it missed 2/3 of sepsis cases, and it rarely found cases medical staff did not notice, and frequently issued false alarms. And one of the issues is this is a proprietary algorithm from Epic. And so the fact that the only way that the University of Michigan was able to uncover this was by comparing the outcomes of the sepsis predictor to their own chart review, it says something about it. And so I think it's important to know that as much as we need to trust artificial intelligence and AI, we also have to use our clinical reasoning and our knowledge and our experience to guide those decisions. And so a little bit of trust goes a long way. And so after all of that, are we useless, or are you out of a job as an anesthesiologist? And I'd say the answer is no, or I don't think we'd be here. But technology solves these problems narrowly. We've seen how much good it can do in terms of viewing echoes, predicting hypotension, helping us to manage our insulin and glucose perioperatively. But there's no generalized AI on the horizon that can be you or do your job in the way you do, even with every article that's coming out about ChatGPT. The output is really a statistical prediction more than anything, and it doesn't work well outside of these trained data sets. Physicians are fundamentally trained to reason and act under uncertainty. So these models work because there's so much data going in and so much information that's able to come out. But you, at the end of the day, are able to use uncertainty and guide clinical decisions through that. So I think that the future moving forward, the best approach is to augment human intelligence, like we talked about at the beginning, to provide patients with the best care that we can give them. Thank you.
Thank you so much. Great talks by our speakers. Let's give them another little round of applause. Thank you. At this point, we're going to do the Q&A portion of the session. If you have a question, for either of our speakers, please feel free to come to our microphone, or we can bring you a microphone as well. And we will need microphones for our speakers as well. I'm going to kind of start off while people kind of get their questions in mind. I have a question for Dr. Humaydan about you mentioned these different exercises and the importance of finding kind of our patients' baselines cognitively, preoperatively, and then possibly doing things to kind of augment their cognitive reserve. Is there a way, or have you had any success in your own institution with engaging with our surgical colleagues to kind of help them see the importance of this as a risk factor? Just like we engage with them about risk, modifiable risk factors with like diabetes and cardiovascular disease.
Good question. So my approach at Ohio State has been to try to position the anesthesiologist as the ultimate perioperative physician. And so my approach is to try to take some of that burden off of the surgeons and just defer to us, because it is hard to get them engaged in things that are not directly, like surgical, I feel like. So, they understand that when postoperative complications go up, that affects them. But even with like diabetes, there's still a struggle, especially if there's an urgency to the surgery, like it's for cancer. You have a harder time getting buy-in on some of those preoperative interventions because there's that sense of urgency. So my approach has been to try to show them that if we have a centralized process where they can send their patients and then they can trust that everything will get done, that's maybe the best way to be consistent in screening our patients, intervening on them before surgery, and making sure that everything's ready to go so that they have the best possible outcomes. That's kind of the approach I've taken so far. There is interest in the research that I'm doing. I think they think it's kind of neat and interesting. But overall, I think the more that we can leverage our perioperative expertise to offload some of that from them, the better that they are about letting us do that, and the better the likelihood, hopefully, that the patients will get what they're supposed to get. It's hard. Right now we have 3 or 4 different preoperative pathways that patients can get plugged into. It ranges from nothing, like the surgeon's clinic feels like that the patient really doesn't need anything and they'll just go ahead and book surgery. It ranges from that end of the spectrum all the way to a visit with our preoperative testing clinic, and a couple things in the middle that might be a phone call or something along those lines. So we're trying to get everything under one umbrella so that we're not missing patients that need more evaluation, and that we're not doing these very thorough things on patients that really don't need it, but that requires coordination at a high level, which I think the anesthesiologist is the right person to do it. So that's the approach I've taken so far.
Just to piggy off back of that, this kind of reminds me of, some of the things we're doing in our own preoperative clinic at Vanderbilt with like nutrition and really just any comorbidity management. But I think this sounds like a really important piece that we need to plug into these clinics, because as you say, the infrastructure is typically in many institutions already there. Some patients are going to these clinics already for other optimization measures, nutrition, any preoperative testing that they may require. And this could just be another piece that, we can add, which, could be tremendous benefit to them. Is there any other place other than like a preoperative clinic where we could do kind of this screening? Is there a utility in doing it in the pre-op holding room, or is this really something that needs to happen, weeks to months before surgery?
So both, actually. So I have a study a pilot study I just started recently where we are doing a self-administered cognitive reserve assessment on a tablet or on a computer with the patients in pre-op holding. It's a feasibility study because, I appreciate that even though we know we should be screening, actually doing it is very challenging. These clinics are not always staffed up as well as they could be. It's another thing that we're asking people to do if we're asking them to do a cognitive screen. Some places are taking the approach of, we know we should be doing nutrition, we should be doing cognition, we should be doing frailty. We're just going to do frailty. We're just going to do one and try to get that really high risk patient population. But even that's challenging. So I think ideally, we would get patients at a point early enough in the perioperative planning process where we could do something about their risk factors. But for the cognitive stuff in particular, even just knowing in pre-op holding, we could still do something. So an example of that is if we screen a patient in pre-op holding and we say, okay, they have indication that their reserve is low, maybe that would push us toward not giving them benzodiazepines for anxiolysis if that was something that we were considering doing. Or maybe, we give their caregiver, some sort of a handout. There's some really nice information available with Dr. Blitz's webinar. There's some patient education you could give their loved one that says, like, these are the things you want to look for if your loved one's not quite acting right after surgery. It's not to scare them, it's just to help them feel empowered so that they don't just dismiss it as normal changes after surgery because that's kind of the culture, the way it's been. Well, of course, grandma's not right. She got a bunch of anesthesia, and we're kind of understanding that that's not necessarily the right way. So if we could catch them in pre-op holding, that would be better than nothing. And then also it would help allocate resources post-operatively. Maybe they get sent to a room that has a window as opposed to an internal room that doesn't. So some of those basic interventions I think could still be fired even with just capturing the risk in pre-op holding. But I don't know how feasible it is to do that. I'm trying to study it right now, and it's tough. It's very tricky, but delirium and cognition being so important, I'm hoping that we'll eventually get there professionally where we do it more consistently. So.
That's fantastic. Thank you. I think we have a question from one of our audience members.
Hi, Mike Favreau from the University of Miami. You kind of were touching on what I wanted to ask. So if you do these screening assessments and you find these at-risk patients, I mean, you mentioned benzodiazepines, but I wonder if anyone's looked at, is there some role in modifying how the anesthetic is given or the depth of anesthesia we run the patients through, if you're doing any of that or if that's something on the horizon?
Yeah, so that's an area of intense debate right now. The original studies looking at some of these things, as far as like the anesthetic management, they kind of went looking at a general versus a regional technique, or like for hip fracture or something like that. If we keep the patients under a general anesthetic, is their outcome affected compared to a patient we do with an epidural that doesn't, get a general anesthetic? Those studies early on were confounded by the fact that when blocks were done, the patients got Versed to help them tolerate the block. So it wasn't totally clear. There was no difference in the way that the patients did, depending on general versus regional, but it had some confounding factors. Since then, the studies have been done more intentionally, and it hasn't played out that there's a benefit from one type of an anesthetic versus another. It also hasn't played out that a particular inhalational agent's better than another or any of that. It's just hasn't been clear that there's benefit to do, this particular approach. What I think that there is clear evidence for is in older people avoiding what they call the Beers criteria medicines, which are the benzodiazepines. Older people shouldn't be really getting tramadol. They shouldn't be getting meperidine. And then as far as what to do intraoperatively, keep their hemodynamics as I guess, physiologic as possible. So you don't want to aggressively hyperventilate people unless you have a reason to. I see that all the time in the OR where we're just like driving down their CO2. And in my mind, theoretically, that can affect their perfusion and all that stuff. We have reasons why we do that sometimes, but it shouldn't be just standard. Watch their hemodynamics. Don't tolerate long periods of hypotension because they're about to make incision or it's about to be stimulating part of the case. Go ahead and support that pressure and get it back up to normal. The depth of anesthesia monitoring has not played out the way I had hoped. I had hoped that if we monitored EEG or we used a device to do that, and we titrated the anesthetic, that would have a benefit. It has not played out that way. And there's studies that show that there is benefit. There's studies that show there isn't benefit. It's very controversial. If you're using something that's a processed EEG, like a BIS monitor or something like that, if you're watching the raw EEG, where you're actually looking at the signal, which we don't have the capability of at Ohio State, I know some places do, you can do some things like avoid burst suppression, which is most ideal probably. But with the processed EEGs, that capability is heavily confounded. So the things that, like the recommendations say you should monitor EEG, but it doesn't recommend a particular way to do it. So my bias is to do it with the raw signal and try to avoid clear evidence that they're over-anesthetized based on the waveforms. In lieu of that, things that are really reliable that you can do is adjust your MAC for their age. As you get older, your MAC requirements go down. So an old person does not need the same amount of gas as a young person. Those types of simple things can hopefully make a difference. But yeah, the EEG stuff is heavily controversial, and I'm hoping that one day it'll be clear what we need to do, but we're not there yet. So stick to the basic stuff: hemodynamic stability, avoid Beer's medications, and titrate your MAC based on their age.
Thank you. And thank you for your audience question. While we're seeing if any other individuals have any questions, I have a question for Dr. Gruss that kind of piggybacks on some of this that we're talking about as far as delirium and postoperative cognitive dysfunction. I know you didn't specifically talk about that, but you do mention these clinical support tools and these pop-ups and how we can utilize those to better care for patients. Is there a way to maybe feed, do some machine learning to feed a data set of like elderly people with certain cognitive dysfunctions, and then have certain like pop-ups occur in the OR? Would that be beneficial? Is that, I guess kind of touch on some of the reality of that?
So the one thing that comes to mind is there's these systems that are used everywhere outside of the U.S., targeted controlled infusions of like propofol, which are based on pharmacokinetics and pharmacodynamics. And there's some good data that shows that you can use, rather than using those targeted controlled infusions, you can actually have artificial intelligence in a neural network better predict a BIS or an EEG reading than those classical models. So I think there's technology there to use data and data points to better predict the level of depth of anesthesia. I haven't seen any. I mean, I'm sure there will be something out there in terms of using artificial intelligence to read EEG waveforms over BIS or SedLine or whatever device you might have, and I think hopefully that's the future, because sometimes I feel like we're dealing with a random number generator in some of these anesthetics where the BIS is 40 or the SedLine is reading this, but you have like a MAC of volatile. I just feel like sometimes they're not reliable. It speaks back to that black box again of things that I don't like. I don't like anything that's proprietary. I think if you can't corroborate or validate it yourself, you should do your anesthesia with one eye open. So I think that's on the horizon in the sense of being able to use true EEG waveforms or the raw waveforms to better help us make clinical decisions. We'll see when that comes in.
I would love to be.
Wonderful.
I'll say one other quick thing.
Yes, absolutely.
When we're talking about how to get people to buy into this stuff, it was not apparent to me when I started doing this at OSU how important giving people feedback on their outcomes is. And I'm trying to do that at a physician level right now with my surgeons because I do enhanced recovery at OSU, so that's a much broader perioperative quality paradigm than just focusing on delirium and cognition. But, it's a very powerful motivator when you can give people feedback. And so even though I have put in all of our protocols that you should be doing these screens, I don't have the capability right now of giving people the data back that how often are they doing it? What are those patients' outcomes? I'm just saying this is what we should be doing. Eventually, hopefully, we'll get there with our data capabilities. But I think that's going to be the most important piece of getting people on board, because then if they see, hey, this lift that we're being asked to do is actually translating to better outcomes in our patients, not in a study, not in somebody else's institution, in the people we're taking care of, I think that that'll be the most important thing that will help pivot us toward getting better buy-in. But it's hard. It's really hard to do that. It's hard. Yeah.
And one of those databases that I referenced, that MPOG database, we've actually rolled out at Vanderbilt like a compliance that we're compared to our peers in our department, which show what our risk, what our rate of patient AKI, PONV, reintubation, and we get those emails weekly, and it compares ourselves to everyone else in our department. And so I think it really makes you take a second look at your performance metrics, like train of 4 monitoring is on there too. So just comparing your practice patterns to your colleagues, and I think it's a really good way to increase compliance, because like you said, if you're seeing that you're not doing anything to mitigate delirium and all of your colleagues are, like, you'll probably change your behavior. And MPOG has said on that a national level that they've had that measurable, that people have made measurable statistically significant improvement in their practice patterns just based on telling somebody that they're bad. Not in more or less ways. But.
No, and I definitely can personally speak to that as somewhat a receiver of those emails. You look and see, and it gives many different metrics from, hypotension prevention to temperature, monitoring, train of 4. And it makes me, and especially the fresh gas flow thing, it makes me, pay more attention to that in the OR. I'll come into a room, and if I see the fresh gas flows really high, that's something I'm on right now, because we're highlighting people in our department who are champions of low fresh gas flows. So I want my name to be on one of those lists, and so I go into the operating room and I turn down those flows, and it's just another tool to help me pay attention to some of these things. So I think that really speaks to that feedback component. Also, our ERAS, each ERAS service line gets feedback. I get a monthly email on my service line of how we're doing in all of our various metrics, and that just allows us to then say, okay, well, this past month we were not so good on this. In the previous month we were better on that, whether that's, minimizing opioids or, again, temperature monitoring, antibiotic, PONV prophylaxis, all of those things. We kind of get like a green box or a red box, and that feedback has been profoundly helpful into us making these little tweaks to just make things better. Because there's one thing to say we need to do all of these things, and it's another thing to really strive to pay attention to this on the daily basis. And it is hard for all of us. We have so many different variables that we're looking at, so many different things we're trying to pay attention to, and it's really hard to tease out these one little things, but together they really make a difference. So you guys are really doing good work to really highlight some of these things and bring that to, our patients and improve their care. Other questions from any audience members? This was a really great session. Thank you all so much. Thank you to our speakers. Thank you for our questions. I just had a few housekeeping Things before we go. If you want to provide feedback on this session, please complete an evaluation in the app. You can select on this session from the agenda and then select the survey button to answer a few questions about the session if you have any feedback.